thank you very much, Marie-Hélène et Jochen, and everyone who invited us. Merci beaucoup pour nous avoir ici. C'était vraiment super. So I couldn't thank Alexandra Dürr more for her introduction, because she clearly set the stage of the problem why we need to work together in these trials. So every one of you who is working with ALS patients knows about the heritability, and about 10 to 15% of all these patients coming to your clinics and have genetic background. And so we would have a lot of people to participate in trials like that or in similar trials, but actually it's quite difficult to get these people to participate in these trials. And I think Alexandra Dürr pointed out very clearly why it is so difficult for patients and also for the pre-symptomatic carriers to first want to know about the result, and then make even the next step to participate in a clinical trial which might deal with a disease which they have not developed yet. So it's really a very wonderful introduction. And I give this presentation also in the name of Laura, who you also have seen, who is really an incredible help with this. And I just want to show you this, and you're all very familiar with that. That's a concept of how we think neurodegenerative diseases might develop. And we all know that many of these diseases have a long prodromal and also maybe a pre-symptomatic phase, and that molecular changes need to appear in that time, that we have a time where we probably have some phenotransition, which then comes into phenoconversion. With some signs in ALS, for example, with muscle weakness, it might be easier to detect this. And in some symptoms, like behavioral symptoms or cognitive symptoms, it might be much, much more difficult to say when actually the time of phenoconversion is. And I chose this slide to show you because this is something which you know from this publication from Michael Benatar, whom I'm really admiring a lot for his PREFAL study. And this is an exemplary way of how one biomarker could behave. And this is, in this case, it is NFL. But you also know that maybe if you have looked into the recent literature, that there are potentially also biomarkers who could behave completely different. That there is also data from large epidemiological trials that maybe we have also some markers which increase and then decrease again. So this is also something which we might face in this trial. So what did we set out to do? And you have seen this already, and this came out, not quite sharp. But anyway, you have seen this already. So it's the layout of that's the conversion problem between Mac and PC. Okay. You see that we're trying to collect subjects who are pre-symptomatic and carry a mutation for an ALS gene. And we collect these subjects at the moment in 7 different countries. And we also collect people who are controls, and usually they're the spouses or friends of the same age. That was important for us. And at the same time, we're also collecting subjects who are symptomatic patients, because we think that one of the fingerprints that we might detect should probably also be visible with the very same methods, with the very same collection methods. And I think this is important for the entire study, also in symptomatic patients. And I want to stress this point a little bit more because so one of the things is, of course, to collect biomaterial. And you all collect in your individual studies biomaterial, but one of the things which we made a real prerequisite for the premodiALS study is to have very rigorous SOPs to collect this biomaterial, so we can be very sure that everything which was collected is very comparable also across these different cohorts of patients. And some of the analysis which we have foreseen, we have predefined, and some of the biomaterial which we are collecting, and this is also important for everyone who is interested in that, is open also for collaboration and also for use as a biobank. So where are we at the moment? These are the countries and who are participating in premodiALS at the moment. And you see that we started out with France, Israel, Switzerland, Slovakia, Turkey, and Germany. And very recently also a center in the Czech Republic joined. And we have at the moment 233 participants who underwent the initial baseline visit. And then 135 of them already went into the 1-year follow-up visit, and some of them even in the second follow-up visit. So we have ethical approval now for up to 5 follow-up visits. And you also see that we have collected a nice number of biomaterials, which is of course not the same for CSF as for urine and tears. And this is also something which we're collecting. So we're not only collecting blood and CSF, we're also keen on analysis of tear fluid. You have heard from Antonia yesterday what the possibilities could be, and also for urine analysis. And for the genetic breakdown here, we have in the pre-symptomatic subjects, we have, this is a breakdown, we had 66 subjects, and we have, of course, many subjects with C9 mutations, but also SOD, and of course also the usual suspects. And of course also in the early ALS, we have these subjects here who have a genetic background, which would be interesting to compare. Now, some of the analysis, as I said, were predefined, and these analyses are currently ongoing. So we're collaborating with Mary Louise Rogers from Australia, who is an expert in P75 extracellular domain detection in urine, which is an interesting biomarker, probably not only as a diagnostic biomarker, but also as a prognostic biomarker. And we are collaborating with Nick Ashton on the new LISA and some of the data you have seen today. But we are also performing proteomics from the tear fluid stripes, proteomics, so LCM, SMS from the plasma and serum and CSF samples. And we have just recently came in data from the metabolomics and lipidomics analysis, also from plasma and CSF. Now, this is ongoing work, and some of it you have seen, but I wanted also to focus on another aspect which we're assessing. So the reason to design a protocol like premodiALS was, on one hand, to get a maximum of information, but on the other hand, also to be as lean as possible, because all of you are, at least that's the case for us, we're working in clinics and seeing patients, and sometimes it's difficult to say, okay, we're getting the patients here or the pre-symptomatic subjects, and they stay for 2 days, and we do all kinds of examinations with them. That's excellent if you can do it, but some centers probably can't. So we wanted to have a lean protocol, but at the same time, analysis which are meaningful. And one of the things which have been interesting also in other degenerative diseases is the loss of smell. And you can actually test this quite easily using the brief smell identification test. It's a short version of the UPSID, and basically looks like this. It's a little booklet, and you scratch, and you know this from when you go to perfume stores and want to test new perfumes, so you can scratch and see if it's good. And that's something which you get here. And then you can identify the smell. And it's also important to say that this is culture dependent. So we have different versions for the different countries. And indeed also, there are also different smells which people are used to smell. So we have done a first analysis with a cohort of 180 subjects, and this is the table of that, and this is ongoing work, but we thought it would be interesting to have a preliminary analysis already now. So we included about the same number of controls in pre-symptomatic and early ALS patients and some mimics. And you see here that in the first baseline analysis, it's not significant, but you can see that there is already a tendency here to a decreased smell perception in the early ALS subjects. That has been described actually. And after 1 year, this becomes significant. Now, we were interested in seeing whether in this very heterogeneous group, because we have different mutations, if there is anything which one could say about this group. And indeed, when we look into that, then we see that actually the subjects who have an SOD mutation, that they are actually the driving force for a decreased smell perception, in contrast to the C9 or the TDP patients here, subjects here. And this becomes even stronger after the first year follow-up, although of course the numbers are quite small here. But so we're looking forward to getting more results here. And this I will just skip because you have just seen that from Laura, who has also presented this data on the new LISA analysis. Another thing which I wanted to mention is a questionnaire which we're implementing, and that makes the first baseline visit actually much longer than the follow-up visit. And this is a questionnaire where we are asking risk factors, but also exposition to different environmental toxins or substances. And this is actually a study which we started before premodiALS. It was the early ALS study where many centers in Germany from the MND net participated, and patients were filling out this questionnaire themselves. One of the things which we can already see here is that, for example, patients who developed ALS later, they said that they visited the neurologist much significantly more frequent in the time up to 1 year before the manifestation of the disease, but also significantly in the time of 1 to 5 years before. So we didn't ask what the reasons were, but that was the visit to the neurologist. And also interestingly, also the visit to the speech therapist was significantly more frequent also in this time up to 5 years before symptom onset in patients who have developed ALS later. We also see a decrease and decline in weight, although maybe not as strong as has been described in other cohorts. So we see it only significant at the completion of the questionnaire, but you see that this curve starts to insignificantly drop here already a while before. If you look at questions for example, physical activity in sports, then you see that overall, the dark, the black here, that's overall patients, and red are females and blue are males. And you see that intensive occupational physical activity is much more frequent in ALS patients, and also that has been described, but it's mainly driven by the male patients here. And for the substance use, it's interesting that patients with ALS indicate that they previously consumed caffeine, but now stopped drinking coffee, and maybe even more than the control subjects here. And on the professional degree, we also see something which might also correlate with this physical activity, that the subjects with a higher university degree, they are less frequent among those who develop ALS, and maybe have more in vocational training, which they have actually performed. So this is what we used to design then the questionnaire for premodiALS, and implemented an improved version of this questionnaire into the premodiALS protocol. The protocol itself has been published, and I'm showing it here because this is really an invitation to collaborate. So we provide the protocol and we provide the SOPs. We also provide the ECRF where data can be entered, and we also provide all the material that you actually need to collect it, like the micronic racks and also the BSIT. Everything you have to do in your center is to see the patient, to evaluate the patient, and to take the biosample. So what is currently ongoing in premodiALS? We continue the recruitment of new subjects, and we follow up with the recruitment of the subjects who are already in the study. Up to V4 is now approved. We try to harmonize also with other consortia which are ongoing worldwide, and we try also to make premodiALS larger. So we just associated the center in the Czech Republic, also another center in Germany. And I'm particularly fond of saying that with the help of a Filsland grant, we could associate 6 further French centers here. And so thank you very much for doing this. In Lille, in Paris, in Limoges, Clermont-Ferrand, and Nice and Lyon. And in Turkey, we have one center which now changed. And in Italy, there will be a new center in Bari, actually, which will participate. One thing which we are adding at the moment, and also adding to the leanness of the protocol, is speech analysis. So maybe you have heard that you can use artificial intelligence to also evaluate speech, human speech. And there is a startup company which specialized in speech analysis, and they claim that with the analysis they are performing, they can make assumptions about cognition, about speech itself, of course, but also about emotional recognition, and also about respiration, which you can clearly also identify when you listen to someone speaking. So this has been, this is currently implemented, and this will be speech analysis where the subjects can just dial in. It's not very tedious for the subjects, takes about 20 minutes, and they can do it as often as we would like them to do. So basically they could also do it once per month, but we think every 3 months would be a reasonable time. And of course, we have a subset of these analyses ongoing. If you want to have more information about the study, we have also a website where this is also described. And we have also a news section where we try to update about the activities of this project. And with that, I'm closing, and I have to thank many people who have been contributing to that. And I thank particularly the French centers who are now members of premodiALS.
Yeah, Paul, thank you very much for this introduction of the premodiALS consortium, I think one can say. Is there any immediate questions? Yeah, there's one.
The smell difference that you have in SOD1, they were older, no? The SOD1 carrier were older than the others, or
just
not?
a little bit, but they're still presymptomatic. Yeah, so they're in total a little bit older than the other C9
And when you correct
carriers,
for age, do you still have the difference? Did you do it? You
that
did
was
correct?
corrected, yeah. Mm-hmm. Mm-hmm.
Mm-hmm.
One thing that we've seen in this SOD1s is the RBD. It's not everybody, only a few mutations. So I wonder if that is a question for the presymptomatic as well.
We ask really a lot of symptoms, and I would be pretty sure, although I don't know the questionnaire completely out of my mind, that REM sleep behavior disorder or and at least restless legs is part of the questionnaire. Yeah.
Okay, there's no other questions. Then the next talk will be given by Johannes Dorst. So.